Good afternoon, dear students, and today we're going to start this third lecture in gastroenterology course. The topic will be peptic ulcer disease and other stomach and duodenal ulcers. Peptic ulcer is defined as disruption of the mucosal integrity of the stomach and duodenum greater than 3 to 5 millimeters, leading to a local defect or excavation due to active inflammation. Also, burning epigastric pain exacerbated by fasting and improved with meals in the symptom complex associated with peptic ulcer disease. It's now clear that more than 90% of patients with this symptom complex, dyspepsia called, do not have ulcers, and the majority of the patients with peptic ulcers are asymptomatic or could be asymptomatic. Duodenal ulcers occur most often in the first portion of the duodenum and near the pylorus. Gastric ulcers tend to occur late in life than duodenal lesions, with the peak in sinus reported to the 6th decade. More than one-half of gastric ulcers occur in males and less common than duodenal ulcers. Gastric physiology and anatomy. The stomach occupies a small area immediately distal to the esophagus. The upper region, the fundus, under the left diaphragm, the mid region, or called also body, and the antrum, which extends to the pylorus. The smooth muscle of the wall of the stomach has 3 layers: outer longitudinal layer, inner circular, and innermost oblique layers. There are 2 sphincters, the gastroesophageal sphincter and the pyloric sphincter. The latter is largely made up of the thickening of the circular muscular layer and controls the exit of gastric contents into the duodenum. The duodenum, here it is, has outer longitudinal and inner smooth muscular layers. It's C-shaped and the pancreas sits in the concave. Here not clearly seen, but also. It terminates at the duodenal flexure, where it joins the duodenum. The mucosal lining of the stomach can stretch in size with feeding. The greater curvature of the underdistended stomach has 6 folds or rugae. The mucosa of the upper 2/3 of the stomach contains parietal cells that secrete hydrochloric acid and the chief cells that secrete peptinogen. There is often a color change at the junction between the body and the antrum of the stomach that can be seen macroscopically and confirmed by measuring surface pH. The antrum mucosa secretes bicarbonate and contains mucus-secreting cells and G cells, which secrete gastrin, stimulating acid production. There are 2 major forms of the gastrin, depending on the number of the amino acid residues. Mucus-secreting cells are present throughout the stomach and secrete mucus and bicarbonate. The mucus is made of glycoproteins called mucins. The mucosal barrier, made up of the plasma membranes of the mucosal cells and the mucus layer, protects the gastric epithelium from damage by the acid, for example, different toxic drugs as aspirin or NSAIDs, alcohol, or bile salts. Prostaglandins stimulate secretion of the mucus, and their synthesis is inhibited by aspirin and NSAIDs. The duodenal mucosa has villi, like the rest of the small bowel, and also contains Brunner glands that secrete alkaline mucus. This, along with the pancreatic and biliary secretion, helps to neutralize the acid secretion from the stomach when it reaches the duodenum. The gastric epithelium is under constant assault by a series of endogenous noxious factors, including hydrochloric acid, pepsin or pepsinogen, and the bile salts. In addition, a steady flow of exogenous substances such as medication, alcohol, and bacteria encounter the gastric mucosa. The mucosal defense system can be envisioned in a three-level barrier composed of pre-epithelial, epithelial, and sub-epithelial elements. The first line of defense is a mucous bicarbonate phospholipid layer, which serves as physico-chemical barrier to multiple molecules, including hydrogen ions. Mucus is secreted in a regulated fashion by the gastroduodenal surface epithelial cells. It consists primarily of the water and mixture of phospholipids and glycoproteins. The bicarbonate secreted in the regulated manner by surface epithelial cells of gastroduodenal mucosa into a mucus gel forms a pH gradient ranging from 1 to 2 at the gastric luminal surface and reaching 6 to 7 along the epithelial cell surface. The second line of the defense is surface epithelial cells provide including mucus production, epithelial cell ionic transporters that maintain intracellular pH and bicarbonate production, and intracellular tight junction. Surface epithelial cells generate heat shock proteins that prevent protein denaturation and protect cells from the softening factors such as increased temperature, cytotoxic agents, or oxidative stress. Epithelial cells also generate trefoil factor family peptides and catalysidins. An elaborate musculovascular system within the gastric mucosal layers is the key component of the subepithelial defense or repair system. Moreover, this microcirculatory bed provides an adequate supply of macronutrients and oxygen while removing toxic metabolic byproducts. Several locally productive factors, including nitric oxide, hydrogen sulfide, and prostaglandin, contribute to the vascular protective pathways through the vasodilation of the microcirculation. Prostaglandins play a central role in the gastric epithelial defense repair. The gastric mucosa contains abundant levels of prostaglandins that regulate the release of mucosal bicarbonate and mucus, inhibit parietal cell secretion, and are important in maintaining mucosal blood flow and epithelial cell restitution. The gastric immune response to certain pathogens such as Helicobacter pylori involves extensive interplay between innate and adaptive components. H.pylori and pepsinogen are the two principal gastric secretory products capable of inducing mucosal injury. Gastric acid and pepsinogen play a physiological role in protein digestion, absorption of iron, calcium, magnesium, and vitamin B12, and killing undigested bacteria. Basal acid production occurs in the circadian pattern, with highest levels occurring during the night and lowest levels during the morning hours. Cholinergic input via the vagus nerve and the histaminergic input from the local gastric sources are the principal contributors to basal acid secretion. Stimulated gastric acid secretion occurs primarily in the three phases based on the site where the signal originates: cephalic, gastric, and intestinal. Sight, smell, and the taste of the food are the components of the cephalic phase, which stimulates gastric secretion via the vagus nerve. The gastric phase is activated once food enters the stomach. This component of secretion is driven by the nutrients that directly and indirectly stimulate the G cells to release gastrin, which in turn activates the parietal cells via direct and indirect mechanisms. Distension of the stomach wall also leads to gastrin release and the acid production. The last phase of the gastric secretion is initiated as food enters the intestine and is mediated by luminal distension and nutrient assimilation. The GI hormone somatostatin is released from endocrine cells found in the gastric mucosa, it's D cells, in response of H.pylori. Somatostatin can inhibit acid production by both direct parietal cell and indirect mechanism. Ghrelin, the appetite-regulating hormone expressed in GR cells in the stomach and its related peptide motilin, may increase gastric acid secretion through stimulation of histamine release from ESL cells. The acid-secreting parietal cell is located in the oxyntic gland, and it's important for the gastric secretory process. This unique cell also secretes instrinic factor and interleukin-11. Binding to histamine to the H2 receptor leads to activation of the adenylate cyclase and the phosphoryl pathways, in turn of regulating an increase of cyclic adenosine monophosphate and intracellular calcium respectively. Activation of the gastrin and muscarinic receptors result in activation of protein kinase signaling pathway. Each of these signaling pathways in turn regulates a series of downstream kinase cascades that control the acid-secreting pump and NK-ATP phase. Parietal cells also express receptors for ligands that inhibit acid production. Histamine also stimulates gastric acid secretion indirectly by activating the histamine 3 receptor on D cells, which inhibits somatostatin release. The chief cells, found primarily in the gastric fundus, synthesize and secrete pepsinogen, the inactivated precursor of the proteolytic enzyme pepsin. Many of the secreted GOGs that stimulate acid secretion also stimulate pepsinogen release. There are two major factors of peptic ulcer disorder, either as gastric or duodenal ones. Obtaining of medical history, especially for peptic ulcer disease, H.pylori infection, and digestion of intersteroidal anti-inflammatory glands of smoking is essential in making of the correct diagnosis. Gastric and duodenal ulcers usually cannot be differentiated based on the history alone, although some findings may be suggested, such as anamnesis of the patient, where you can find long-term therapy with NSAIDs, or family history of peptic ulcer disorder, especially father of the patient or any of the relatives has the history of Helicobacter pylori infection. Also, peptic ulcers can be caused by different infections, as cytomegalovirus or herpes simplex, different drugs or toxins, including clopidogrel, glucocorticosteroids, potassium chloride, miscellaneous duodenal obstruction, or other GI disease, as for example Crohn's disease, sarcoidosis, ischemia, or radiation therapy, as all other factors can cause peptic ulcer too. There is a difference between ulcer and erosions. Ulcer can start from erosion, and erosion is necrosis or breach involving only superficial mucosa, as you can see here. Ulcer is necrosis or breach involving the entire thickness of mucosa that extends through the muscularis mucosa into submucosa deeper. Chronic ulcer includes also muscular layer and can even involve cirrhosis in the process. Ulcers are defined as bricks of mucosa surface more than 5 mm in size with a depth to subserosa. Gastric acid output, basal and stimulated, tends to be normal or decreased in gastric ulcer patients. When stomach ulcer developed in the presence of minimal acid levels, impairment of mucosal defense factors may be present. Stomach ulcers have been classified based on their location. Type 1 is gastric body and used to be associated with low gastric acid production. Type 2 occur in the antrum, and gastric acid can vary from the low to the normal. Type 3 occurs within the 3 cm of the pylorus and are commonly accompanied by duodenal ulcers and normal or high gastric acid production. And type 4 are found in the cardia and associated with a low gastric production. Stomach ulcers tend to occur later in the life than duodenal lesions, with the peak in sinus reported in the sixth decade. Moreover, one half of the stomach or gastric ulcers occur in males. In contrast to duodenal ulcers, stomach ulcers can be represented by a malignancy and should be biopsied upon discovery. Benign gastric ulcers are most often found distal to the junction between the antrum and the acid secretory mucosa. They are rare in the gastric fundus and histologically are similar to duodenal ulcers. Benign stomach ulcers associated with Helicobacter pylori are also associated with antral gastritis. In the contrast, NSAID-related stomach ulcers are not accompanied by chronic active gastritis, but may instead have evidence of chemical gastropathy, typified by foliar hyperplasia, edema of the lamina propria, and epithelial regeneration in the absence of Helicobacter pylori. Extension of the smooth muscle fibers into the upper portion of the mucosa, where they are not typically found, may also occur. Gastric infection with the bacterium Helicobacter pylori, well known, accounts for the majority of the peptic ulcer disease, gastric or duodenal. This organism also play a role in development of gastric mucosa-associated lymphoid or multiple lymphoma and gastric adenocarcinoma. And you should remember the presence of Helicobacter pylori is a risk factor of gastric cancer. Also, the entire genome of Helicobacter pylori has been sequenced. It's still not clear how this organism, which resides in the stomach, can cause ulceration in the duodenum. These bacterial eradication efforts may lead to a decrease of the gastric cancer in high-risk population of the patient. The prevalence of these bacteria varies throughout the world and depends largely on the overall standard of living of the region. It's present widely in the developing parts of the world and less present in already developed. The overall prevalence, for example, in the USA, it's around 30%, comparing with 80% of the developing countries. Transmission occurs from person to person following oral or fecal-oral route. Pathophysiology, if we talk about Helicobacter pylori, the bacteria which is able to facilitate gastric residence, induce mucosal injury, and avoid host defense. Different strains of these bacteria produce different virulence factors. These virulence factors, in conjunction with additional bacterial constituents, can cause mucosal damage, in part through their ability to target the host immune cells. In addition, Helicobacter pylori may directly inhibit parietal cells, leading in part to the low acid production observed after acute infection with the organism. Urease, which allows the bacteria to reside in the acidic stomach, generates derivatives which can damage epithelial cells. The bacteria produce surface factors that are chemotoxic for neutrophils and monocytes, which is in turn contribute to epithelial cell injury. These bacteria makes proteases and phospholipases that break down the glycoprotein lipid complex of the mucosal gel, thus reducing the efficiency of the first line of the mucosal defense. Studies in twins suggested that there may be genetic predisposition to acquire this bacteria. The inflammatory response to Helicobacter pylori includes recruitment of the neutrophils, lymphocytes, macrophages, and the plasma cells. The pathogen leads to the local injury by binding the class II major histocompatibility complex molecules expressed on the gastric epithelial cells, leading to cell death, called apoptosis. The reason Helicobacter pylori-mediated duodenal ulceration remains still unclear. Additional mechanisms by which Helicobacter pylori may cause epithelial cell injury include activated neutrophil-mediated production of reactin, oxygen, or nitrogen species, and enhanced epithelial cell turnover, and apoptosis related to interaction with the T cells and inhibitor factor of the tumors. Finally, the human stomach is colonized by the host of commensal organisms that may affect the likelihood of Helicobacter pylori infection and subsequent mucosal injury. Helicobacter pylori associated with duodenal ulceration may be more virulent. In addition, certain specific bacterial factors may be associated with the development of duodenal ulcer. Another potential contributing factor is the gastric metaplasia of the duodenum in patients with duodenal ulcer present, which may be due to high acid exposure, permit of Helicobacter pylori to bind to it, and produce local injury secondary to the host response. Another hypothesis is that the Helicobacter pylori antral infection could lead to increases acid production, increased duodenal acid, and mucosal injury. Basal and stimulated gastrin release are increased in Helicobacter pylori infected individuals, and somatostatin secreting B cells may be decreased. Helicobacter pylori infection might induce increased acid secretions through the both direct and indirect actions and pro-inflammatory cytokines action on GD and parietal cells. The final effect of the Helicobacter pylori on the GI tract is variable and determined by microbial and host factors. Duodenal ulcers are estimated and occur only from 6 to 15% of the Western population. Before the discovery of Helicobacter pylori, the natural history of them was typified by frequent recurrence after initial therapy. Eradication of Helicobacter pylori has reduced these recurrence rates by around 80% and more. Duodenal ulcers occur most often in the third portion of duodenum. They are usually less than 1 centimeter in diameter, but can occasionally reach from 3 to 6 centimeters. They are giant compared with the stomach ulcers. Ulcers are sharply demarcated with depths at the times reaching the mucolaris propria. The base of the ulcer often consists of the zone of eosinophilic necrosis with surrounding fibrosis. Malignant duodenal ulcers are extremely rare. Helicobacter pylori and NSAIDs-induced injuries account the majority of duodenal ulcers, compared with the third factor in the stomach ulcers, which is smoking. Many acid secretory abnormalities have been described in these patients. Basal and nocturnal acid secretion appears to be increased in patients with duodenal ulcers compared to control population. The reason for this altered secretory process is unclear, but Helicobacter pylori infection may contribute. Bicarbonate secretion is significantly decreased in the duodenal bulb of the patient with the active duodenal ulcer as compared to control group of subjects. NSAIDs represent a group of the most commonly used medication in the world, and even 75 milligrams of the aspirin widely used in the treatment of cardiovascular disorders may lead to serious GI ulcerations. Thus, actually, no dose of NSAIDs is completely safe, and don't forget that aspirin is NSAID too. Prostaglandins as actually paracetamol. Prostaglandins play a critical role in the maintaining gastroduodenal mucosal integrity and repair. It therefore follows that interruption of the prostaglandin synthesis can impair mucosal defense and repair, thus facilitating mucosal injury via a systematic mechanism. Injury to the mucosa also occurs in the result of topical encounter with NSAID, leading to increased epithelial surface permeability. Aspirin and NSAIDs are weak acids that remain on the ionized lipophilic form when found within the acid environment of the stomach. Under this condition, NSAIDs migrate across the lipid membranes of the epithelial cells, leading to the cell injury once trapped intracellularly in an ionized form. Topical NSAIDs can also alter the surface mucous layer, permitting back diffusion of the hydrogenum and pepsin, leading to the further epithelial cell damage. NSAIDs can also lead to mucosal injury via production of additional pro-inflammatory mediators like tumor necrosis factor and leukotrienes through simultaneous activation of lipogenase pathway. Pathogenic factors related to Helicobacter pylori and NSAIDs in acid peptic disease also are cigarette smoking, genetic predisposition. Cigarette smoking has been implicated to the pathogenesis of peptic ulcer disease. Not only have smokers been found to have ulcers more frequently than non-smoker population, but smoking appears to decrease healing rates, impair response to therapy, and increase ulcer-related complications such as perforation. The mechanism responsible for increased ulcer diathesis in the smoker is still unknown. Theories have included altered gastric emptying, decreased proximal duodenal bicarbonate production, increased risk of Helicobacter pylori infection, and cigarette-induced generation of noxious mucosal free radicals. Also, ischemic situation in patients who are smoking is still present. Genetic predisposition may play a role in ulcer development too. First-degree relatives of duodenal ulcer patients are 3 times as likely to develop an ulcer. The potential role of Helicobacter pylori infection, in contrast, is a major consideration. Increased frequency of the blood group O and on the non-secretory status have also been implicated as genetic risk factor for peptic diathesis. However, Helicobacter pylori preferentially binds to group O antigens. So group O, or first group, is in the risk of their Helicobacter pylori infection and diseases which this microorganism can actually cause. Diet is also one of the etiological factors and play a role in peptic disease pathogenesis. Certain food and beverage can cause dyspepsia and also peptic other developments. Specific chronic disorders have been shown to have strong association with peptic ulcer disorder as advanced age, chronic pulmonary disease, chronic renal failure, nephrolithiasis, systemic macrocytosis. Disorders with a possible association are hyperparathyroidism, coronary artery disease, polycythemia vera, chronic pancreatitis, former alcohol use, obesity, African American race, and 3 or more visits of the doctor in a year, which can cause possibly a stress. So the main pathogenesis of peptic ulcer disease, this is the prevalence of gastroprotective or mucosal injurious factors on the liver of mucosa defense. If gastroprotective factors will be over, then mucosal injury substances possible, including all etiological agents, histamine and histamine release, drug long-term therapy, etc., there will be no peptic ulcer disease. If gastroprotective factors cannot cover different risk factors of mucosal injury, erosion of mucosa in the future, if patient wasn't treated or mucosal injury is severe, erosion will become an ulcer and can cause in future complications such as, for example, bleeding to stomach or esophagus, irritation of stomach innervation, and other, which we will discuss a little bit later. Signs and symptoms of the peptic ulcer disease may vary depending upon the location of the disease and age. Gastric and duodenal ulcers can be differentiated from the timing of their symptoms in relation to the meals, but keep in mind this differentiation only by timing of the symptoms relation to meals or concomitant symptoms are very relative, and the diagnosis of peptic ulcer disorder can be made, but the exact place where the ulcer patient has is very preliminary. Gastric pain is the most common symptom of both types of the ulcers, that characterized by gnawing or burning sensation and occur after meals classically. Short after meals with the gastric ulcer and from 2 to 3 hours afterward of duodenal ulcer. Duodenal ulcer pain often awakes the patient at night. It's fasting pain, I would say. Food or antacid relieve the pain of duodenal ulcer, but provide minimal relief to the gastric ulcer pain. Also, peptic ulcer disorder can be presented with symptoms consistent with anemia. The sudden onset of the symptoms may indicate perforation. NSAID connected or induced gastritis or ulcers may be silent, especially if patients are old. Patients with the gastric ulcers usually can cause, if they are complicated, hematemesis or melena. Duodenal ulcer patient can also have these symptoms, but not so frequent. Heartburn, chest discomfort are common for both types of the ulcers. In patients with a gastric ulcer, patient would tell you that its early satiety bothers him, comparing with patient with duodenal ulcer where early satiety are not so common, but comparing with heartburn and chest discomfort. Gastric ulcer, please notice that can be a risk factor of gastric carcinoma. And for patient duodenal ulcer, as we already said, it's a fasting pain. Fasting can be nocturnal pain. Other symptoms include except epigastric abdominal pain, bloating, abdominal fullness, nausea, vomiting, weight loss or weight gain, depending. A complicated ulcer can cause appearance of hematemesis or melena. Hematemesis is the vomiting of the blood, which may be obviously red or have an appearance similar to coffee ground, depending on what portion of the blood of the patient actually vomited. Melena is the passage of the black tarry stool. It has a characteristic of tarry color and offensive smell, and it's often difficult to flush away, which is due to the alteration and degradation of the blood by intestinal enzymes. Offensive smell due to degradation of the proteins. Hematochezia is the passage of the fresh blood per annus, and usually in or with the stool. You can see here it is, it's melena, here it is hematochezia. Hematochezia more commonly seen in patients with Crohn disorder or different type of rectum disorders. A physical exam may reveal epigastric abdominal tenderness and signs of anemia. Epigastric tenderness is the most frequent finding in patients. In uncomplicated peptic ulcer, the clinical findings are few and non-specified and include the following. Gastric tenderness, usually mild, right upper quadrant tenderness in case of biliary etiology means biliary reflux is the cause of the ulcer. Guaiac-positive stool resulting from cold blood loss, melena resulting from acute osobacum gastrointestinal bleeding in patients with complicated peptic ulcers, suction splash resulting from partial or complete gastric outlet obstruction in case of complicated peptic ulcers. Patient with perforated peptic ulcers is usually present with a sudden onset of severe sharp abdominal pain. Most patients describe generalized pain, a few present with a severe epigastric pain. As even slight movement can tremendously worsen their pain, the patient assumes a fetal position. Abdominal examination usually discloses generalized tenderness, rebound tenderness, cardium. Alarm symptoms or warning symptoms that should prompt urgent referral patient to the surgeon include unintentional weight loss, usually more than 10 kilos in the 3 months, progressive dysphagia, overt gastrointestinal bleeding, iron deficiency and anemia, especially severe degrees, or recurrent emesis, and family history of gastrointestinal malignancy. Iron deficiency anemia could appear in patients as a cause of gastrointestinal bleeding, or the problem with B12 metabolism, depending on. Differentiating between H. pylori and NSAID-induced ulcer. The 100% correct diagnosis can be established only based on endoscopy, but preliminary some suggestions can be made. So if patient has ulcers associated with Helicobacter pylori, except in amnesis, these ulcers more often appears in duodenum, usually superficial, and less severe gastrointestinal bleeding in case of complication. In case of NSAIDs, more often than stomach, patients have an anamnesis long-term therapy with NSAIDs or cardiovascular disorders where aspirin treatment can be induced, or different, for example, autoimmune or connective tissue disorders where glucocorticosteroid long-term therapy usually used. These ulcers are usually deep, has more severe GI bleeding as they are deep and sometimes can be asymptomatic, means silent, and means more difficult to find and treat, and more common complications can be found due to silence of them, of this type of the ulcers. Diagnostic evaluation. Helicobacter pylori management recommendations include such as all patients with active or past history of the peptic ulcer disease, low-grade gastric mucosa-associated lymphoid tissue lymphoma, or history of endoscopic resection of early gastric cancer, patients with dyspepsia who are undergoing upper endoscopy, patients on long-term low-dose aspirin, patient initiating long-term therapy with non-steroidal anti-inflammatory agents, patient with unexplained iron deficiency anemia following the standard workup, adults with idiopathic thrombocytopenic purpura should be diagnosed and treated in Helicobacter pylori infection. American guidelines also recommend post-treatment testing to prove eradication of Helicobacter pylori with the use of urea breath test, fecal antigen test, or biopsy-based testing at least 4 weeks following completion of antimicrobial therapy and after proton pump inhibitors have been withheld for 1 or 2 weeks. Testing for Helicobacter pylori is essential in all patients with peptic ulcers. Endoscopic or invasive tests for Helicobacter pylori include a rapid urease test, histopathology, and the culture. Rapid urease tests are considered the endoscopic diagnostic test of the choice. The presence of Helicobacter pylori in gastric mucosal biopsy specimen is detected by testing for the bacterial product urease. Fecal antigen testing identifies acute Helicobacter pylori infection by detecting the presence of Helicobacter pylori antigens in stool. This test is more accurate than antibody testing and is less expensive than urea breath test. 3 kits are commercially available for Helicobacter pylori testing, and each contains a combination of urea substrate and pH-sensitive indicator. 1 or more gastric biopsy specimens are placed in the rapid urease test kit. If Helicobacter pylori present, bacterial urease converts to urea to ammonia, which changes the pH and resulted in a color change. Urea breath test detects active Helicobacter pylori infection by testing for the enzymatic activity of the bacterial urease. In the presence of urease produced by Helicobacter pylori, labeled carbon dioxide is produced in the stomach, absorbed into the bloodstream, diffused into the lungs, and is exhaled. Obtaining histopathology often considered the criterion standard to establish a diagnosis of Helicobacter pylori infection. If the rapid urease test result is negative and high suspicion for the Helicobacter pylori persists, especially in presence of duodenal ulcer. Antibodies to Helicobacter pylori can be measured in the serum, plasma, or whole blood. Results with the whole blood test obtained from finger sticks are less reliable. Remember that stool antigen test in this case more sensitive and cheaper than serology. Before urea breath test testing, patients should discontinue antibiotics and bismuth compounds for at least 4 weeks, and the proton pump inhibitors and sacralfate for at least 2 weeks if patient was treated previously to this test. This medication can reduce the urease activity of Helicobacter pylori and can generate a false negative result. Histamine 2 receptor antagonists should be ideally discontinued up to 48 hours before the testing to avoid a false negative results. Use of NSAID is permitted. Urea breath test detects active Helicobacter pylori infection, and how exactly it can be managed we already discussed. On the picture you can see how this test looks like and exactly the mechanism of the test on this picture. Another test is histology, as Helicobacter pylori is a spiral-shaped bacterium that can be seen in hematoxylin and iodine staining, and the sensitivity and specificity of this stain has been reported around 93% and up to 90% respectively. Hematoxylin in stain can directly identify Helicobacter pylori. Please look at that picture, in a high magnificent field and evaluate the degree of inflammation. NGM stain is easy to use, inexpensive, and provides consistent result. It's a preferred method in many laboratories. The major advantages of hematoxylin and iodine stain include shorter screening time and high specificity because it can exclude other similar shaped organisms. The advantages of histology includes its ability to document Helicobacter pylori infection, and it also provided more information about the degree of inflammation and associated pathologies such as atrophic gastritis, intestinal metaplasia, gastric cancer, or lymphoma. However, it has several limitations, including high cost, longer turnaround time, and depends on the skills of the operator. Endoscopy provides the most sensitive and specific approach for examining the gastrointestinal tract, upper or lower part either. In addition, to permit indirect visualization of the mucosa, endoscopy facilitates photographic documentation of a mucosal defect and tissue biopsy throughout malignancy of Helicobacter pylori infection. Endoscopic examination is particularly helpful in identifying lesions too small to detect by radiographic examination for evaluation of typical radiographic abnormalities or to determine if an ulcer is source of the blood loss. As you can see here, this is one of the ulcers that can be source of the blood loss complicated by bleeding. Endoscopy is required to document healing of the gastric ulcers and to rule out gastric cancer. In case if you want to rule out gastric cancer, you should remind that it should be done biopsy and not less than 4 times from different angles of the gastric ulcer to not miss the malignancy in this patient. This usually is performed from 6 to 8 weeks after the initial diagnosis of the PEPTIC ulcer, and documentation of Helicobacter pylori cure with a non-invasive test such as urea breath test or fecal antigen test is appropriate in patients with complicated ulcer. On the picture you can see how it looks like gastric ulcer or duodenal ulcer. Despite the gastric ulcer in this picture looks like bigger or similar to gastroduodenal ulcer, but you can see that gastroduodenal ulcer involvement of mucosa around is bigger than in patient with gastric ulcer. The ulcer looks deeper and more chronic with more callous edges than in patient with the gastric ulcer. Barium X-ray imaging of the proximal GI tract are rarely used as the first test for documenting on ulcer. The sensitivity of the older single contrast barium mills for detecting of duodenal ulcer is high, up to 80%, with a double contrast study providing detection rates at highest 90%. Sensitivity for detection is decreased in small ulcers less than 0.5 centimeters with presence of previous scarring or in post-operative patient. Duodenal ulcers appears as well-demarcated crater most often seen in the bulb. Here it is. Typically, benign gastric ulcer also appears as a discrete crater with a radiating mucosal fault originated from the ulcer margin. Ulcers more than 3 centimeters in size or those associated with the mass are more often malignant. Unfortunately, up to 8% of gastric ulcers that appear to be benign by radiographic appearance are malignant by endoscopy or surgery. Radiographic studies that show gastrointestinal ulcer must be followed by endoscopy and biopsy. Here how it looks like gastric ulcer, duodenal one, here duodenal one. You should remember that there are several contraindications for performance of endoscopy for the patient, such as, for example, old age, severe cardiovascular disorders, severe liver disorders, inability of the patient to swallow this actually endoscopic tube, strong vomiting reflexes, and etc. For example, different of esophagus disorders as a possible concomitant cancer, which makes endoscopy impossible for this patient. And in this case, barium X-ray imaging will be a choice and the possible method of evaluation of ulcer disorder. But in the contrast of this situation, as we already mentioned, if you have found a gastrointestinal or stomach or duodenal ulcer, especially if this is a small ulcer or ulcer with actually big folder, maybe callus or non-clear edges, this barium X-ray imaging, if possible, should be followed by endoscopy with possible biopsy and histology to prove that there is no complicated ulcer present. Stool antigen tests are appropriate where the prevalence of Helicobacter pylori infection is less than 30% in population. Positive stool test antigen is highly predictive in presence of this infection. Helicobacter pylori disappears quite quickly from the stool after eradication. Therefore, positive results indicate persistent active infection. To avoid false negative results, patients should be off antibiotics at least 4 weeks and off proton pump inhibitors and bismuth at least 2 weeks. H2 receptor antagonist and acid preparation are allowed. So the part of the stool will be distanced or diluted in reagent, and then were placed in this bottle should be placed a paper with additional reagent which shows presence or absence of antigen of Helicobacter pylori. And let's go to the approach and therapy of peptic ulcer disorder. The referral to a gastroenterologist is for the potential need of endoscopy and subsequent evaluation and treatment if the endoscopy is negative. Once an ulcer is documented, the main issue at stake is whether Helicobacter pylori or NSAIDs is involved. With Helicobacter pylori present, independent of the NSAID status, triple therapy is recommended for 14 days, followed by continued acid-suppressing drugs for a total from 4 to 6 weeks. Helicobacter pylori eradication should be documented 4 weeks after completing antibiotics. The test of choice for documenting eradication is a laboratory-based validated monoclonal stool antigen test or urea breath test. The patient must be off anti-secretory agents when being tested for eradication of Helicobacter pylori with urea breath test or stool antigen. Serologic testing is not useful for the purpose of documenting eradication because antibody titers fall slowly and often do not become undetectable. Gastric ulcers, especially of the body and the fundus, have a potential of being malignant. Multiple biopsies, that's why should be taken initially. Even if these are negative for neoplasm, repeat endoscopy to document healing at 8 to 12 weeks should be performed with biopsy if the ulcer is still present. Repeat endoscopy is warranted in patients with duodenal ulcers if symptoms persist despite medical therapy or complication is suspected. Gastric ulcers that fails to heal after 12 weeks and duodenal ulcers that does not heal after 8 weeks of the therapy should be considered refractory. The guidelines indicate that selection of Helicobacter pylori management regimen should take into account any previous antibiotic exposures. The following therapeutic strategies for the first-line treatment: 10 to 14 days of bismuth quadruple therapy, particularly in those with previous macrolide exposure or other penicillin allergy. 10 to 14 days of concomitant PPI, clarithromycin, amoxicillin, and nitro-imidazole. 14 days of clarithromycin triple therapy should be reserved for patients with no previous history of macrolide exposure, live in the regions where clarithromycin resistance among Helicobacter pylori patient isolates and is known to be low. 5 to 7 weeks of sequential therapy with PPI and amoxicillin, followed 5 to 7 days with clarithromycin, a PPI, and nitro-imidazole can be an option of the therapy. 7 days of hybrid therapy with PPI and amoxicillin, followed by 7 days with a PPI, amoxicillin, clarithromycin, and nitro-imidazole can be another option. From 10 to 14 days of levofloxacin triple therapy can be an option, and 5 to 7 days of fluoroquinolone subsequential therapy, followed by 5 to 7 days PPI, fluoroquinolone, and nitro-imidazole can be another option. Salvage treatment is if the first-line therapy fails and Helicobacter pylori persists. Include the following options: avoid previously used antibiotics. Preferred for patients who previously received first-line clarithromycin regimens is bismuth quadruple therapy or levofloxacin salvage regimens. For patients who previously received first-line bismuth quadruple therapy, clarithromycin or levofloxacin containing salvage regimen preferable. Salvage treatment regimens include following: bismuth quadruple therapy or levofloxacin, avoid clarithromycin triple therapy, concomitant therapy for 10 to 14 days, rifabutin triple regimen, or high-dose dual therapy for 14 days. How to choose the antibacterial drug to start the treatment? At first, you should ask the patient if there are any penicillin allergy or penicillin used previously, and if they are previously used macrolide for any reason, including different infection of the skin, respiratory infection, etc., especially 3 months before the Helicobacter pylori treatment. If there is no penicillin allergy and no macrolide exposure previously, you can start from any regimen we already named. Also, when you choose regimen, please ask patient, does patient have some maybe medication concomitant for different disorders except Helicobacter pylori infection? Did patient receive any antibacterial treatment, not only macrolide or penicillin? You should consider patient live in the clarithromycin resistant or not area. So, and then to choose the drug. If, for example, previously patient was treated with, I don't know, for example, clarithromycin 3 months before Helicobacter pylori you want to prescribe, so start from other one like levofloxacin. If patient has previously 3 months before the Helicobacter pylori treatment eradication, actually, for example, severe bacterial pneumonia and was treated with levofloxacin, please start from clarithromycin triple with amoxicillin strategy of Helicobacter pylori eradication. If patient has no allergy to penicillin but macrolide exposure, recommended treatment will be bismuth quadruple therapy. We already talked in previous lecture, and you have a scheme there. Different levofloxacin triple or sequential regimens for Helicobacter pylori irradiation. If there is allergy on penicillin and macrolide exposure, recommended treatment will be only bismuth quadruple therapy. Here you can see dosages and the regimen for standard or not therapies offered for eradication. Usually, except eradication of Helicobacter pylori, we are using different drugs helping us to relieve the pain of the patient and to decrease actually secretory part of peptic ulcer pathogenesis. So one of them and the most frequently used are NSAIDs, which promote gastric mucosal defense mechanism and secretion of the mucus, used as protective barrier bicarbonate, which helps to buffer acidic properties of H.pylori and prostaglandins, which can prevent activation of proton pump, which results in decreasing actually acidity too. You should remember that there are 3 main types of NSAIDs, so magnesium, aluminum, and calcium supplies, and they have different effects depending on the main components, such as aluminum contain antacids can cause constipation. Also, for example, magnesium preparation can have laxative properties. Calcium preparation may result in kidney stones. Sodium ions can lead to hypertension. Repeated use of calcium carbonate as antacid may lead to excessive amounts of calcium ions being absorbed into the body and lead to kidney stones or other different stone appearance, for example, gallbladder stones, etc. The most frequent one used and known, I think, is gaviscon. It's aluminum hydroxide preparation combined with magnesium or Malox. Malox as calcium preparation. Another type of the drugs is already known by you, H2 receptor antagonists. They can inhibit acid production by reversibly completing with the histamine for binding of H2 receptors on the basolateral membrane of the parietal cells. Block histamine from stimulating the acid-secreting parietal cells of the stomach, and H2 agonists also mainly basal physic neurogenic gastric secretion is suppressed and and other stimuli as gastrin, alcohol, food is also can be inhibited. 4 of these agents are presently available: cimetidine, ranitidine, famotidine, and nizatidine. Famotidine and nizatidine are younger than their old colleagues, ranitidine and especially cimetidine, which is the first line of these drugs. They structural share homology with histamine. Cimetidine may weak anti-androgenic side effects, resulting in irreversible gynecomastia and impotence, primarily in patients receiving high doses of prolonged periods of the time. In view of cimetidine ability to inhibit cytochrome P450, careful monitoring of the drugs such as warfarin and theophylline, etc., is indicated for long-term therapy usage. Ranitidine, famotidine, and nizatidine are more potent H2 receptor antagonists than cimetidine, but ranitidine can cause decrease of the sexual ability of the male patient, so you should remember about it. Each can be used once a day at bedtime for ulcer prevention. Nighttime dosing regimens are cimetidine 800 milligrams, ranitidine 300 milligrams, famotidine 40 milligrams, and nizatidine 300 milligrams. Another acid neutralizing drugs are PPI or proton pump inhibitors, including omeprazole, lansoprazole, rabi or pantoprazole, substitute benzimidazole derivatives that convalently bind and reversibly inhibit HK-ATP phase, inhibiting gastric acid secretion. They are the most potent acid inhibitory agents available in the first line in the treatment of the peptic ulcer, different gastritis, and dyspepsia patients. Omeprazole and lansoprazole are the PPI that have been used for the longest time. Both are acid-labile and administered as enteric-coated granules in sustained release capsules that dissolve within the small intestine at pH around 6. Lansoprazole is available in an orally disintegrating tablet that can be taken with or without water. It's an advantage for the patient with significant dysphagia. Panto and rabiprazole are available as enteric-coated tablets. Panto also available as the parenteral formulation for intravenous use, such as famotidine also exists in parenteral formulation for intravenous use. These agents are lipophilic compounds. Upon entering the parietal cells, they are protonate and trapped within the acid environment of the tubulovesicular and canicular system. They are potentially inhibit all the phases of acid secretion. Onset of action is rapid with the maximum acid inhibitory effect between 2 to 6 hours after administration, and duration of inhibition lasted around 96 hours in some patients, or from 72 to 96 hours. Serum gastrin levels return to normal levels within 1 to 4 weeks after drug cessation. Long-term acid suppression, especially with the PPI, have been associated with a high incidence of community-acquired pneumonia due to decreasing of eliminating ability of the acidic content of the stomach to destruct bacteria, and also the long-term therapy with PPI is the risk factor of the gastric cancer. This type of preparation should be given 30 minutes to 1 hour before food intake because acidic pH in the parietal cells acid canicule is required for the drug activation, and food stimulates acid production. Concomitant use of the PPI with H2 receptor usually reduce the action, but can be used if prescribed in different times. For example, PPI in the morning and H2 before the night time. If PPI treatment doesn't effectively decrease secretion in patient with peptic ulcer. Another drug which can be used as cytoprotective and can decrease gastric acid content damage of the epithelial cells. They are bismuth containing preparation. Colloidal bismuth subcitrate and bismuth subsalicylate are the most widely used preparation. Bismuth is the highly insoluble complex of trivalent bismuth and salicylate. The mechanism by which these agents induce ulcer healing is unclear, but they are cytoprotector and they cover the surface of the epithelial cells and helps to protect from damaging action of the gastric acid contain. These components are commonly used as one of the agents in anti-pylori, Helicobacter pylori regimen, but long-term usage with the high dosages can lead to neurotoxicity. The mechanism of action of bismuth on gastrointestinal pathogen, including the Helicobacter pylori, are complex and include inhibition of the protein and the cell wall synthesis, membrane function, and ATP synthesis. Adherence of the Helicobacter pylori to surface epithelial cells are also impaired. Acid neutralizing drugs class sucralfate. Sucralfate is a complex sucrose salt in which the hydroxyl groups have been substituted by aluminum hydroxide and sulfate. This compound is insoluble in water and becomes a viscous paste within the stomach and the duodenum, binding primarily to the sites of active ulceration. Sucralfate may act by several mechanisms, serving as physicochemical barrier, promoting the trophic action by binding of the growth factors, enhancing prostaglandin synthesis, stimulating mucus and bicarbonate secretion, and enhancing mucosal defense and repair. Toxicity from this drug is rare, and constipation the most common side effect. It should be avoided in patients with the chronic renal insufficiency to prevent aluminum-induced neurotoxicity. Hypophosphatemia and gastric bizarre formation have also been reported, but rarely, and standard dosing of sucralfate is 1 gram 4 times a day. Nowadays is used in treatment of peptic ulcer, very rare, but can be a drug, additional drug if previous drug are failed or their effect is not enough. There is no complete improvement of the symptoms in your patient case. Taken on the empty stomach 1 hour before meals uses can be used prescribed for treatment of NSAID-induced ulcers, patients with continued smoking, topically burn or exacerbated ulcers. Another acid neutralizing inhibitory drugs are prostaglandin analogs. In EU, central role is maintaining mucosal integrity and repair. Stable prostaglandin analogs were developed for the treatment of peptic ulcer disorders. The mechanism by which this rapidly absorbed drug provides its therapeutic effect is through enhancement of mucosal defense and repair. They can inhibit gastric acid secretion, exhibit cytoprotective activity, enhance local production of mucus and bicarbonate, promote local cell regeneration, help to maintain mucosal blood. Blood circulation means, yep. The most common toxicity noted with this drug is diarrhea, but it's not really common. Other major toxicities include uterine bleeding and contractions. Misoprostol, which is the most frequent used prostaglandin analog, is contraindicated in women who may be pregnant, and for women of childbearing age, they must be made clearly aware of this potential drug toxicity. The standard therapeutic dose is 200 nanograms 4 times a day. NSAID ulcer treatment includes different strategies, including injurious agents should be stopped at the first step in the therapy of the active NSAIDs-induced ulcer. If that is possible, then treatment with one of the acid inhibitory agents, you should remember PPI is the first line of the agents, is indicated. Cessation of the NSAIDs is not always possible because of the patient's severe underlying disorders, as, for example, bronchial asthma severe, or connective tissue disorders, or autoimmune disorders, etc. Only PPI can heal gastrointestinal and duodenal ulcer, independent on whether NSAIDs are discontinued. The widespread use of NSAIDs has created some concern due to increasing likelihood of the GI or cardiovascular side effects associated with these agents. The approach to primary prevention has included avoiding of the agent, using the lowest possible dose of the agent for the shortest period of time, using dual topical NSAID preparation instead of general, and using concomitant medical therapy to prevent NSAIDs-induced injury. So if patient receives long-term therapy with NSAIDs, it's reasonable to prescribe for him curative dosages of protective dosages rather of PPI from 7 to 14 days, depending on the length of the treatment and underlying condition of your patient. Primary prevention of NSAID-connected ulceration can be accomplished by prescription of misoprostol alone or in combination with PPI. High dosage of H2 blockers has also shown some promise in preventing of these ulcers, and gastric protection therapy is required for individuals who are taking COX-2 type of NSAIDs and or patient is on aspirin prophylaxis. Patient without cardiovascular risk factors but with higher potential risk of NSAIDs-induced injury, even if it's COX-2 inhibitor, should receive co-therapy with misoprostol or high dosages of PPI. Individuals in moderate gastrointestinal risk without cardiac risk factors can be treated with COX-2 NSAID type of COX-2 inhibitors NSAID types alone or with non-selective NSAID with misoprostol or PPI. You should remember that even if NSAID is COX-2 inhibitor, they still have a side effect as potential GI ulceration or erosion appearance. So protective therapy should be prescribed from time to time. Surgical intervention in patients with peptic ulcer disorder can be viewed as being either elective for treatment of medically refractory disease or as urgent emergent for the treatment of an ulcer-related complication. Refractory users are an exceedingly rare occurrence. Surgery is more often required for treatment of ulcer-related complication. Hemorrhage is the most common ulcer-related complication. In a quarter of patients can be seen. Bleeding may occur in any age group, but is the most often seen in older patients. The majority of patients stop bleeding spontaneously due to small, vessel disruption in the presence of peptic ulcer. Free peritoneal perforation occurs very rarely in up to 3% of duodenal ulcer patients. With NSAID-induced gastrointestinal perforation occur more commonly. Pyloric channel ulcers or duodenal ulcer can lead to gastric outlet obstruction in similar to up to 3% of patients. Surgical treatment was originally designed to decrease gastric acid secretion. Operations more commonly performed include vagotomy or drainage. If your preparation and treatment with PPI, H2 blocker, etc. are not effective, highly selective vagotomy with atherectomy. Two principal types of renostomosis is used after atherectomy as gastroduodenostomy bilirubin 1 and gastroduodenostomy bilirubin 2, which you will discuss during your surgery lessons. Differential diagnosis. The following condition can be present with the symptoms similar to peptic ulcer disease, and it's important to be familiar with their clinical presentation to make correct diagnosis and to differentiate peptic ulcer with many other disorders, as peptic ulcer in your patient will not look like as a classic peptic ulcer you can see in the books. And many patients, especially older ones, have plenty of concomitant disorder which can mimic or hide the real clinical problem of them. So gastritis is inflammatory process of the gastric mucosa from immune-mediated or infectious etiology. We talked in previous lectures, presenting with the upper abdominal pain and nausea. Clinical presentation is very similar to the peptic ulcer disorders. So should remember that Helicobacter pylori can be also the cause of gastritis, and differential diagnosis using endoscopy or other imaginary studies should be used. GRD or gastroesophageal reflux disease patient usually describe their abdominal pain as a burning sensation in epigastrium and lower duodenal area, excess salivation or intermittent regurgitation of the food material. Patient with peptic ulcer can have concomitant GRD, but it's extremely rare, and to differentiate GRD from peptic ulcer, as the patient of acid contained in the mouth cavity, presence of regurgitation, symptoms, burning sensation in retrosternal area, burning sensation after big amounts of food, or for example physical activity, or after some tight clothing they wear on. Gastric cancer presented as abdominal pain. Patients usually describe alarm symptoms as weight loss, presence of melena, recurrent vomiting, or evidence of malignancy elsewhere in case the patient has metastatic disorder. Pancreatitis, represented by epigastric or right upper quadrant pain, is more persistent and severe. Patient pain appearance worse in the supine position, and patient usually have a history of alcoholism or gallstones, or it can be NSAIDs or corticosteroids exposure, or for example treatment after anti-cancer treatment, different types of elevated serum. It can be also appearance of acute pancreatitis after infection disorders such as herpes infection or influenza infection. Elevated serum amylase and lipase are useful in the diagnosis to differentiate it from the peptic ulcer. Biliary colic, represented as intermittent severe deep pain in the right upper quadrant or epigastrium, precipitated by fatty meals. Cholecystitis can be represented by the right upper quadrant or epigastric pain that usually lasts 4 hours, and exacerbated by fatty meals is associated with nausea, vomiting. Fever, tachycardia, positive Murphy sign, leukocytosis, and abdominal liver function abnormal parameters help further distinguish this one from biliary colic. Some potential life-threatening conditions that can also have similar presentation as peptic ulcer includes myocardial infarction, especially in inferior wall and right ventricle involvement. Sometimes patient can present with only epigastric pain with nausea and vomiting. The presence of other symptoms like dizziness, shortness of the breath, and abnormal vital signs, the high-risk patient should be alert the clinician to look like. Patient can show you that such manner to help you to understand that he has severe pain, retrosternal one, or in the epigastric area. So you should remember that even if patient has peptic ulcer, history anamnesis or family anamnesis, this patient with such type of pain, epigastric or retrosternal pain, they should be in burning, especially carotid pain, they should be referred on ECG to exclude myocardial infarction as the cause of the pain. Mesenteric ischemia can represented be with the severe acute onset of abdominal pain. The chronic variant usually presents with ongoing postprandial epigastric pain and can be mistaken for peptic ulcer disease. Older age, presence of risk factors for atherosclerosis, weight loss should be prompt for workup for the same. Usually mesenteric ischemia is due to or thrombosis or atherosclerotic blockage of the normal blood flow. Mesenteric vasculitis, represented by unexplained abdominal symptoms with or without lower gastrointestinal bleeding in the patient with other features from underlying systemic vasculitis, and this patient should raise the suspicion of mesenteric vasculitis. As in mesenteric ischemia and in mesenteric vasculitis, the main cause of the pain is ischemia or ischemic damage of the tissue. Comparing with peptic ulcer. Complication of the peptic ulcer. Upper gastrointestinal bleeding, gastric outlet obstruction, perforation, penetration, and gastric cancer. Upper gastrointestinal bleeding can be represented by anemia, pale skin, loss of the blood pressure, tachycardia, vomiting with the blood, or melena. So remember about it. Perforated peptic ulcer. Perforation, in easy words, is the hole of the wall of the stomach, and this hole is open to the open abdominal space, represented by sudden onset severe generalized abdominal pain, tachycardia, board-like rigidity of the abdominal wall, distension, obstipation, fever may be present, maybe not, depending on when this perforation happened, hypotension in late stages when peritonitis will appear. Penetration, the same hole in the wall of the patient's stomach or duodenum, but underlying for this hole will be any organ of the abdominal cavity. It can be pancreas, it can be liver, it can be even gallbladder. Also penetrates the full thickness of the stomach or duodenal wall, progressing into inherent underlying tissue, particularly the pancreas or liver. Penetration manifests clinically as severe back pain with the signs and symptoms of pancreatitis or peritonitis or a liver hemorrhage, depending what exactly is the area of penetration. Gastric outlet obstruction resulting from usually duodenal ulcer or incomplete obstruction typically present with the symptoms of gastric retention, including early satiety, bloating, epigastric fullness, indigestion, anorexia, nausea, vomiting, epigastric pain, and weight loss. Patient can vomit with big amount on the food, especially yesterday eaten food. They are frequently, these patients are malnourished, dehydrated, and have metabolic different type insufficiency. Weight loss is frequent when condition approaches chronicity and is most significant in patients with malignant disease as a cause of this obstruction. Gastric cancer symptoms include weight loss, presence of anemia, especially iron deficiency, anemia, presence of malignization, which can appear as, for example, a liver disorder, a kidney problem, constipation, or diarrhea, depending on what kind of gastric cancer presentation patient have. Also, its neoplastic syndrome can appear. It's represented usually by subfebrile fever appearance, constant usually or from time to time. It's usually patient dehydrated it can be symptoms of pain in the muscles, severe weakness, or any other representation. One of the complications of the ulcer, or actually one of the disease that can present as an ulcer, but this is not an ulcer, but ulcer-related condition with symptoms similar to the apeptic ulcer, is the Zollinger-Ellison syndrome. This pathology should not be mixed with peptic ulcer disorder, such as this pathology is more malignant than peptic ulcer disorder, usually presented with complication, and this complication are severe. Diagnosis the main problem of the patient is hypergastremia originating from autonomous neoplasm, is the driving force responsible for this disorder. Gastrin stimulates acid secretion through gastrin receptors of parietal cells and by inducing histamine release from other cells. Gastrin also has a trophic action on gastric epithelial cells. Long-standing gastremia leads to markedly increased gastric acid secretion through the both parietal cell stimulation and increased parietal cell mass. Diagnosis is made by biochemical measurement of gastrin and acid secretion if patients suspected to this disorder. Often patients suspected on Zollinger-Ellison syndrome will be treated with PPI in an effort to ameliorate symptoms and decrease the possible acid-related complication. All gastronoma patients have a gastrin level more than 150 to 200 picogram on milliliter. Measurement of fasting gastrin should be repeated by confirming of the clinical suspicion. And the biochemical diagnosis of gastrinoma is being confirmed. The tumor is located, and endoscopic ultrasounds permit imaging the pancreas with a high degree resolution and actually to locate the tumor. So treatment is of course surgical with PPI prescription to decrease acidity of the patient. One practical question for you left. It's a pregnant lady in first trimester comes to you with peptic ulcer disease. What kind of drug you will prescribe for her? You should also remember that pregnant ladies in any trimester, especially in the late trimester, can have appearance of the gastroesophageal reflux disorder due to increasing of pressure inside of abdominal cavity with the growing fetus up from first to third trimester. So in this case, as in the case of this pregnant lady, the option is NSAIDs or sucralfate treatment. Usually the most frequent one is NSAIDs because they are cheaper, frequently used, easy to remember, and patient can bear them easily. Why? They are preferable as H2 agonist can cross placenta and also can secrete to the breast milk. And safety of proton pump inhibitors not established in pregnancy yet, and misoprostol, as we already discussed, can cause abortion. So NSAIDs or sucralfate is the option for the pregnant ladies in case of peptic ulcer disorders or GRD or dyspepsia present. And I'm thank you for your all attention. I appreciated you was with me during this lecture. So if you have any questions, please put them or under this lecture YouTube in YouTube, or you can actually send your question to my email, which can be easily found on our page in our Facebook or site. So thank you very much and have a nice day.